bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, the Children's Hospital Foundation of Saskatchewan, and Trillium Health Partners. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAFC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAFCTweets and using the hashtag CAFCPresents. All of our webinars are recorded and can be found on the CAFC Knowledge Exchange Network. Use the CAN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAFC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive. All right, hello everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And today we're going to be talking about using routinely collected health data for research and quality improvement, the importance of methodology, validation, and transparency. And it's my pleasure to welcome back Dr. Eric Benchimol to our CAFC Present stage. But before we get on to that, I just wanted to mention, this is our last chance to mention the CAFC annual conference that's coming up in just a couple of weeks, October 22nd to the 24th in Montreal, at the Sheraton downtown in Montreal. So still an opportunity for anyone who would like to register. Some of the sessions are full, and the hospital tour is always popular. Many of them are full as well, but there's still lots of activities that people can register for. The rest of the conference, the main program, etc., still has lots of spots in it as well. But so it's certainly an opportunity to meet in person some of the webinar audience that we get a chance to speak with every week virtually, but it'd be a great chance to meet some people in person if you're able to attend. So make sure you go to the conference website at conference.cafc.org and check that out. All right, so as I mentioned, it's my pleasure to welcome Dr. Eric Benchimol back to the CAFC Presents stage. Dr. Benchimol joined us, it must be a year or so ago. He's one of the first people I ever followed on Twitter as someone who's in the pediatric medical community that was on social media way back, and he joined us with a number of other colleagues to talk about using social media. And you can follow Dr. Benchimol at Eric Benchimol. And Dr. Benchimol is an associate professor in the Department of Pediatrics and the School of Epidemiology, Public Health, and Preventative Medicine at the University of Ottawa. He's also a pediatric gastroenterologist at the Children's Hospital of Eastern Ontario at the IBD Centre, and you can follow them on Twitter at ChioIBD. He's also the director of the Health Information Technology Program at the CHIO Research Institute, and he's a scientist at the Institute for Clinical and Evaluative Sciences. So it's my great pleasure to welcome back to the CAFC Present stage Dr. Eric Benchimol. Over to you.
Thank you very much, Doug. I appreciate it. And I'm going to share my screen now, or I guess I was already sharing my screen, so that's it. It's great. And let's dock this. Actually, let me try to lower this down so it doesn't block my screen. Sorry about that. All right, ready to go. So I appreciate the introduction and I appreciate the invitation to come and speak. The last time I spoke was about social media, as Doug mentioned. This one is a little bit more in terms of my research interest and certainly more scientifically driven, but I hope you will find it useful as well and practical and applied to you in your field. And I'm happy to take questions at the end. So from what I understand, this is a fairly mixed audience of healthcare administrators, policymakers, clinicians, and other healthcare professionals. However, we're all united in the reason we entered pediatric healthcare, and for me, that's really to make a difference in children's lives. Some of us do it through clinical care, some of us through health policy in the hospital or in government, and some by impacting social policy and social determinants of health. Because of our focus on improving the lives of kids who are suffering, there's an urgent need within us to act and change care based on the latest data and evidence we have. And that's certainly better than it was probably 25 years ago, where we changed care based on expert opinion or eminence-based medicine, and now we're in evidence-based medicine. But I'm here to still urge you to slow down and be cautious. We're going to talk about the huge amount of data available from the healthcare system, data which we could act on immediately. However, please don't. That's my bottom line message. We need to examine these data more carefully and examine the methods that we use to conduct research, measurement, and quality improvement using these data before we act. The policy decisions made by policymakers, whether they be at the local hospital administrative level or within government, are clearly guided by many different aspects. While research and scientific evidence is only a small piece of this policy pie, I believe it does have an impact, especially when research shows findings from the full healthcare system, sort of the population-based findings that we can see in data in Canada. Health services research in particular is influential to policymakers as it reflects how the healthcare system is functioning in real life. So as health services researchers use larger data sets, we have the ability to influence policy a bit more readily than, let's say, basic scientists or even clinician scientists. And that being said, I would still urge caution. We need to keep sight of the methods we use to produce this research, or we could influence policymakers in the wrong direction. The availability of big data, which we'll define in a minute, the availability of big data in many sectors is influencing our lives. While the healthcare sector is hardly alone in the temptation to use big data, the impact of using the data incorrectly has potentially life-threatening implications in healthcare. I think big data has also influenced how scientific and medical researchers look at evidence as well. We used to consider translational research to be the idea that findings made in the laboratory are brought to the patient bedside to influence clinical care. The gap between the bench and the bedside was considered the valley of death by researchers and research policymakers because so few basic science discoveries ever influenced patient care. However, now, with large data sets available, we're able to take findings from the bench and bring them to the bedside, but also have those findings help us examine the functioning of the healthcare system and the health of the population. In addition, using large data sets, we can take findings made at the population level and generate new hypotheses which could be brought back to the bench to try to find the cause of diseases. However, with this expansion, we've gone from 1 valley of death to 4. We've quadrupled our risk, our overall risk in the research enterprise that we may lose data or incorrect findings at the population level could result in wasted research dollars down the road. Incorrect findings at the health system level could result in changes to public health policy or clinical care, which could result in wasted funding or even worse, harm patients. So let's take a step back first and define what we mean by big data. So big data typically is defined using 5 V's, the first being volume, so that's the amount of data that's available. Clearly, if it's big data, it means there's a huge amount of data. Secondly is the velocity, so how quickly the data is available and how quickly it changes. Frequently, when you analyze big data, you minute by minute can find new results based on new data that's come in. There must also be a large variety of different data forms, so different data sources, different origins of the data in order to be considered big data. I think what a lot of people forget when it comes to big data is that one of the 5 V's is veracity, meaning that the data is uncertain and that you don't truly know the accuracy or the validity of the data when you're doing the research. In addition, there has to be value to using big data, meaning that the data is available and ready for use, fairly cheap to use, and at least more cost efficient than collecting data primarily right at the bedside when it comes to healthcare data. So now that we have big data available for health research, I'll show you some examples of what we have available in Canada in a second. There is the temptation to use it to drive health policy, to drive quality improvement initiatives, and I hope you're okay with this picture of temptation. I did a Google image search for temptation, and this was the most G-rated picture that I could find. But we really have to be careful not to give into that temptation to just go about using the data right away. I was at last week, a few of us from the CHIO Research Institute were at Johns Hopkins University to learn, at their medical center, to learn how they're using EPIC data. So the EPIC electronic health record is being used for research and quality improvement, as well as measurement, producing metrics for the hospital. And we were there trying to learn how they're using it. They have an amazing setup for using it for research. And we met with Harold Lehman, a deputy director there, who's deputy director of the Institute for Clinical and Translational Research Informatics Core. And one of the things he asked was, in my hospital at CHIO, how many biomedical informaticians do we have on staff? How many faculty members are biomedical informaticians? And he essentially got a bit of a blank stare from me and my colleague, because we didn't really have that position at CHIO, and it's not really a title that we frequently use in Canada. But then he said, he gave me a good quote that I think really put things into context. He said that computer scientists tell us how to use the health data for research. Biomedical informaticians tell us when we shouldn't use the data for health research. And I think that really put into context that I am, in fact, a biomedical informatician. My interest is in using the data, yes, and trying to find new discoveries using large healthcare data sets, but also learning how to use the data properly, learning how to properly validate, and learning when we cannot use it for healthcare research. So that's the sort of the message of this talk that I hope to give to you, that we have to pay attention to that methodology. So what is routinely collected health data in this catchphrase? Routinely collected health data, when we defined it in the record statement, and I'll talk a little bit more about the record statement in a little bit, but it is defined as data that was collected for non-research purposes or without an a priori research question in mind. And you can replace that with non-clinical purposes or non-quality improvement purposes. The bottom line is that it's data that's collected routinely as part of either provision of clinical care or administration of the healthcare system that we then go back and use for research. And examples of routinely collected health data include health administrative data or claims data, frequently used in Canada, more and more medical record databases, EMRs and EHRs, but also disease registries, including cancer registries, which, you know, maybe the intent is to use it for research, but there's no research question in mind ahead of time. We're just collecting these data routinely with the intent of one day using it for research or quality improvement. It's certainly a growing field. You can see almost exponential growth, at least since sort of the early 2000s. And these are the number of publications in PubMed. It's also a field that is very international, and when you looked at the number of publications back in 2010, you can see that it was really focused on North America and Western Europe using these data. However, more recently, there's been great expansion to other parts of the world, and I think that this expansion is really driven by the availability of the electronic health record in many parts of the world, and the realization that we can use these data. There's that temptation to use these data for research purposes and quality improvement. So it's certainly a growing field of research. In Canada, in the past, we've really been focused on using health administrative data for research. Health administrative data are data that are collected by primarily the ministries of health for the purpose of administration of the healthcare system, not for the purposes of clinical care or for the purposes of research. And examples of frequently used data that we have in Canada include physician billing information, hospitalization data collected by CIHI, prescription medications, emergency department utilization, and procedures as well. In Ontario, we're fortunate enough to have the Institute for Clinical Evaluative Sciences, or ICES, which opened in 1992 in Sunnybrook with the purpose of housing Ontario's health administrative data and using it to improve the lives of Ontarians. Since that time, it's opened in all now academic centers, and this slide is a bit out of date. It is available in all academic centers in the province now, and so researchers in each of those centers can access the data. In addition, it's been made available through a data access sharing agreement, the Data Access Services program of ICES, which is funded by a SPOR. So if you're affiliated with any Canadian university, you can request a cut of the data, put on a VPN for your own analysis. And the sorts of data that we have at ICES include the hardcore health administrative data, things like OHIP, the physician billing databases, the discharge abstract data, Ontario drug benefits data, registered persons data, same-day surgery, the cancer registry, and NACRS for day unit and emergency department use. But it's also been built on to include other sorts of health administrative data, whether it's stroke data, the stroke network, or long-term care, rehab. And more recently, there's been a lot of effort aimed at really expanding the breadth of data that's available beyond just health administrative data in Ontario. So more recently, there's been expansion to immigration data with availability of the immigrant data set. Ministry of Child and Youth Services data should be coming on board soon, Ministry of Education data, social services data, linking electronic health records into ICES, primarily the Emerald database, but others are coming soon. And then born data, with which we have at CHIO, which collects all maternal and child births in the province with some clinical data in there as well. So all of those are all linked together, providing an excellent population-based picture of how things are working in the province in terms of healthcare and the link between social services and social determinants of health and our healthcare system. When we did a systematic review of studies using routinely collected health data, and this was a systematic review published last year that we only sampled 150 studies published over the past 5 years using routinely collected health data for research. What we found, we examined a number of characteristics of the studies included in the review, and there were a few noteworthy things. Firstly, 40% of studies used more than one data source. This meant linking individuals across data sets, potentially resulting in the risk of error and bias, which we'll talk more about that risk later when it comes to linkage across data sets. Secondly, while most of the studies were registry-based studies, there was a large number of studies which used either health or non-health administrative data. In addition, 15% used EMR data. And I would say that if we repeated this review with studies published in the last 2 years or so, the number of EMR studies would have exploded since the number of EMRs in North America really has skyrocketed, and more researchers are being aware that they can use these data for their research. Finally, while most of these studies were epidemiologic studies, many made clinical inferences or examined the healthcare system, and therefore the studies have important implications on public health, health system planning, and clinical care. So Canadian health administrative data really can answer questions like how often do people have this, or how many people are living in a province with this sort of condition or who go through this sort of procedure. How big or not is a problem to the healthcare system? And sometimes these questions are asked directly by health policymakers, and therefore the research that we do can help set or redirect an agenda, a policy agenda, and it can also put background information to set context for decisions on healthcare policy. So we really need to pay attention to how we're using these data. There are certainly some significant advantages to using health administrative data over using data collected primarily for research. Firstly, the data is truly population-based. It's collected on all members of the healthcare system, all people with legal valid health cards in a province, and so you really do have a complete population-based assessment of the entire residents of a province, unlike clinical research data where you have only a sampling based on where you're recruiting patients. It can be used to monitor interventions because we're collecting the data anyway, and they're being documented in the data sets. And so if you put in an intervention in the healthcare system, you can monitor how that intervention works, and I'll show you an example in a second. In addition, it can reflect health system activities, how we're actually using the healthcare system, and reflect real life. It's also cheap and very fast to access. But the reality is, when it comes to big data, fast, cheap, or great, you can only choose two. We never reach that true nirvana there in the middle of that Venn diagram. Frequently, we can only choose two of the three items. And in the case of health administrative data, for the example, it's cheap and it's very fast to access. It's sitting there on a server anyway, and you can conduct research fairly quickly. However, it is not great data, as we'll show in a second. As far as weaknesses, outcomes can be influenced by factors outside of health, which I think is why it's so important to increase the breadth of data that's available to us and linking new data sets in, whether those be clinical data sets to provide more information about clinical care, genomics data sets, for example, but also all of those social determinants of health, social services, Ministry of Education, and other data sets to really understand what other factors are influencing how healthcare is provided. Like I mentioned, that there's a paucity of clinical data, although I think that is changing now that we're linking in EMR and EHR data. Cohort definition can be very, very difficult, as I will show you a fairly in-depth example in about 5 minutes. And the coding accuracy is notoriously poor. So especially when you're dealing with physician billing information, physicians are notoriously inaccurate with how they assign billing and diagnoses associated with those bills, primarily because we're really billing in order to get paid. We're not billing in order to do research. So the coding is subject to the garbage in, garbage out phenomenon, that if you're not getting people who input the codes properly, the research that you're conducting with those codes, unless you validate, unless you're sure of its accuracy, will be inaccurate as well, and you could make bad decisions based on those codes. So that leads to the importance of transparency and why using these data is so important, and why actually measuring how the healthcare system is so important. And I'm going to give you an example of that. It's also an example of where more than just research influences health policy decisions, in our case at the provincial level. And that example was the lean intervention as applied by the province to the emergency departments in Ontario in a province-wide intervention. Lean was originally developed by Toyota. I'm sure most people in the audience are aware of the lean methodology, and it was originally intended to streamline manufacturing and reduce waste and involve frontline workers on the manufacturing floor in providing quality improvement to the process. It's increasingly been applied to healthcare and hospitals, and involving, whether it's in the operating room, in the emergency department, or on the wards, involving frontline healthcare staff to try to improve the care provided to patients, try to reduce inefficiencies and reduce costs as well. It's been implemented in Ontario emergency departments in 3 waves, or at least the overall intervention contained 3 waves. And the intervention really started by a joint report in 2006 from the Ontario Ministry of Health, the Ontario Medical Association, and the Ontario Hospital Association, which essentially called our emergency department wait times, unacceptable. And so the ministry really felt that it was necessary to change things and to try to make care better and more efficient in the emergency department. At the time of the implementation in Ontario, there were really no rigorous studies to evaluate the lean process in emergency department use. So the 3 stages of the intervention that I mentioned included, firstly in 2008, the introduction of a pay-for-performance model, where the Ontario government incentivized the care being provided in the emergency department to try to reduce wait times. Secondly was public reporting of emergency department wait times and benchmarks, as well as the targets that were aimed in 2009. And finally, later that year, they implemented the lean intervention and the lean methodology in the departments across the healthcare system in Ontario. I'm hearing that there might be tapping. I'm not really sure why. I'm on a head mic, so it's not hitting anything. Let me try to mute and unmute for a second again. Okay, so I don't know if that worked or not.
It did stop the sound. It's just like I wasn't sure if maybe you were moving your head and it was just causing the microphone to sort of wiggle back and forth a little.
It's possible. I'm really enthusiastic when I talk. So I might be moving my head. I might even be moving my arms, so you might be hearing the air moving. I'll try to move my head less.
Okay.
So 2009 was the intervention, the 3rd wave, which was the implementation of the lean in emergency departments. So Michael Schull's group actually evaluated the interventions in the emergency departments in this study published in 2014, and did not find good news for the ministry, I think. So essentially what they found was for the main primary outcome that was really desired by the ministry, admitted patients missing the Ontario target, while there was improvement, the improvement really came in the second wave. So you remember the first wave was pay for performance, the second wave was public reporting, and the third wave was the lean. So in fact, the improvement occurred because of either pay for performance, although it doesn't look like that based on this graph, but more likely public reporting and awareness. And when you look at all the other interventions that were examined by this study, essentially you saw the same thing. Where there was improvement, such as non-admitted patients missing the Ontario target or left without being seen, or 72-hour ED revisits among discharged patients, those improvements occurred either in the first or the second wave and not in the third wave. And this was similar. They tried to do a trial to show improvements in emergency departments implementing the lean. And when they looked at it, they found equal improvements as they did in the control group who did not implement the lean, meaning that it wasn't the lean itself, it was the overall, likely the overall awareness that this was a focus of attention by the ministry and by the public, where the emergency department started to act more efficiently and started to work better and provide better patient care. So unfortunately, it seems like the lean intervention in the emergency department did not make much of a difference. And this really contributed to the knowledge that was published by this University of Saskatchewan group, which essentially concluded they did a systematic review of all the lean interventions in healthcare and concluded that really there was absolutely no evidence that the lean interventions, when applied to healthcare, made any difference at all based on the literature. So this is an example of where health administrative data and routinely collected health data can be used afterwards or during an intervention to evaluate how that intervention has worked and make sure that we're really making a difference. And so, I think it's an example of the strength of using these data. However, there are examples of weaknesses as well. And so I really want to focus the rest of the talk on how we can improve the transparency of these data and improve the methods used to conduct research using these data. And so when you think about scientific publications and scientific experiments, there are some scientific principles. If you remember back to your high school days, we all learned about these scientific principles where when you're conducting the experiments should be reproducible. If you reproduce the experiments with the same methods and materials over and over again, you should get approximately the same results. In addition, if the methods and materials are available to other scientists, they should be able to replicate your results. They should be able to find the same findings if they conducted the experiment the exact same way. In order for these to happen, the experiment has to be written up in a way that's transparent. They need to understand how to replicate your results. And so the scientific manuscripts associated with the experiment should present sufficient data so that the reader can fully evaluate the information provided. And that allows the reader, whether it be a clinician, a scientist, or a policymaker, to evaluate the reliability of the evidence as well as the relevance of the study to their population. So when you look at the knowledge creation cycle and the cycle of research, we go from research to publication to knowledge dissemination. There's lots of guidance for scientists when it comes to how to conduct research. Some of us do full degrees in how to do research, whether it's basic science or clinical epidemiology or health services research. There's also lots of guidance when it comes to publishing in terms of guidance on what the journal wants from the manuscript and scientific writing and instruction for authors, as well as the peer review. The whole point of the peer review process is to improve the end publication. Reporting guidelines, research reporting guidelines, really aim to close that gap between research and publication. And so reporting guidelines are essentially checklist items. They're a checklist, the minimum set of essential items necessary to make the study as understandable and transparent as possible and allow for critical evaluation of the reliability of the study. And so what we did recently in an international group was we came to the realization that research using routinely collected health data, health administrative data, and other data was not being adequately reported. The research was not transparent, the methods were not transparent, and so it made it very difficult for people to understand the bias, the risk of bias, and the relevance of the study to their population, and therefore make decisions on that research. And so we created this record statement, the reporting of studies conducted using observational routinely collected health data, as a checklist guide to help people understand what they should be reporting, but also to help consumers of the research, like all of us, clinicians and health policymakers and administrators, understand what should be in the manuscript so that you can make a decision as to whether or not the study is actually good and relevant. And so as part of this process, we recruited over 100 different stakeholders, and because these studies using routinely collected health data, they're often not clinical studies. They might be epidemiologic studies, but they also might be health services research, pharmacoepidemiology research. And so we tried to recruit a broad group of stakeholders, including researchers, policymakers, journal editors, and pharmaceutical industry representatives, to try to understand what items they think are important for inclusion in reporting guidelines in a checklist that would make the manuscript, the scientific publication, transparent to all of these different groups, because all of these different groups are going to be using the research. And these are sort of the top 10 things that the stakeholders felt should be included. And you can see number one, the top is disease and exposure identification algorithms. And I'm going to go into a bit more detail about that specifically, but linkage is also there. Number four, characteristics of the data. All of these were felt to be very important that should be reported in the guidelines. And so we produced this checklist, which is published and is available open access on our website as well, stating exactly which items should be reported properly and how they should be reported with examples. I'm certainly not going to go through all of this full checklist, but just to make you aware that it's available, it's on record-statement.org, and you can access the guidelines and take a look and see what should be in these published articles using routinely collected health data. But I do want to focus on a couple of aspects as an example of where we might go wrong with routinely collected health data. And the record statement 6.1 says that the methods that you use to identify the cohort, the study population, such as the codes or algorithms used to identify study subjects, should be listed in detail. In addition, any validation of these codes or algorithms should be referenced, or if you did it as part of the study, should be included as part of this publication so that the reader knows whether or not the codes were validated. And so I'm going to talk a little bit here about the importance of validation and methodology, and this is where we get into a bit of a nerdy topic, because there's a bit of biostats here, a bit of methods and stuff like that, and certainly, if you saw my glasses, there would be tape on them. I wear contacts, so luckily I don't have to go through that anymore, but I am a little bit nerdy when it comes to data, but hopefully I'll be able to show you how why this is important. And as an example, because I'm a pediatric gastroenterologist, I want to bring up this validation of a cohort of kids with inflammatory bowel disease, which we use to generate the Ontario Crohn's and colitis cohort, which is in Ontario, follows everybody with IBD in Ontario, and is the largest surveillance cohort of IBD anywhere in the world. So the goal, this was part of my PhD thesis, was to develop an algorithm, and I'll define that in just a second, to identify patients with childhood onset inflammatory bowel disease, which is Crohn's and ulcerative colitis, within Ontario's health administrative data. An algorithm is a combination of different codes, whether they be physician billing codes, procedure codes, discharge codes, prescriptions, things like that, that are used when in combination. If a patient has visits associated with those codes, you know that they truly have the disease. And in Ontario, health administrative data is usually associated with a diagnostic code. Luckily, with Crohn's and ulcerative colitis, we have very specifically ICD-9 and ICD-10 diagnosis codes associated with Crohn's and ulcerative colitis. So the algorithm would be combinations of visits to a physician, discharge, procedures, associated with these diagnoses, which when combined accurately tells you that you have IBD, that the patient has IBD within the database. So just like a diagnostic test, when we're validating an algorithm, you need to have a group of true positive reference standard patients and true negative reference standard patients. So true positive, meaning you know that they have IBD, and we use the Sick Kids IBD database for this. All kids diagnosed between 91 and 95 in Toronto, because there were no other pediatric gastroenterologists practicing outside of Sick Kids. We assumed that if you had IBD, you were going to be seen at Sick Kids, and therefore in those years, you had all of the children with IBD in the city of Toronto. That was 183 children diagnosed, and we linked their OHIP numbers and information to the ISIS data. And then as true negative population, the reference standard without IBD, we assume that if you were not in the Sick Kids IBD database, you did not have IBD, and therefore, and you were living in Toronto at the time, you didn't have IBD, and therefore you were considered a true negative reference standard patient. And then just like with the diagnostic test, we used 2x2 tables to try to figure out how accurate the codes were. And so you can see here that having one code, so if a child had one visit, either outpatient or inpatient for IBD, they usually did have at least one code. The sensitivity was 99.5%, so it did pick up the vast majority of those IBD patients, the 183 IBD patients. However, the positive predictive value was only 7.9%. So that meant that for the 183 children with IBD who had one code, there were over 2,000 children who did not have IBD and were not in the database who also had one code for IBD, and those were considered false positives. So, probably those children had, a visit for bloody diarrhea or had a visit for something, and the doctor wrote down rule out Crohn's disease or rule out ulcerative colitis, and it didn't end up being ulcerative colitis, it went away. And so, that's the risk with these codes, is that the accuracy of using one code to identify a patient in this case was really not good. And so, lesson number one from this validation study was don't trust the codes. Really be careful and validate. We're not the first people to validate IBD algorithms in the world. The first was really in Manitoba, where Charles Bernstein's group did it. He found that you required 5 healthcare contacts or admissions within 11 years to accurately be identified as being an adult with IBD. So these were adult-derived algorithms. In addition, there was a group at Kaiser who found that the most accurate algorithm was 2 healthcare contacts within 10 years. And then a group in Alberta found that it was a different algorithm again, 4 healthcare contacts or 2 admissions or 2 ambulatory care visits within 2 years. So 3 different algorithms in 3 different jurisdictions, all showing different accuracy. And so that's lesson number 2, is that algorithms validated in one jurisdiction may not necessarily apply elsewhere. So don't assume that if somebody in the US used an algorithm that it would work in Canada to identify the proper patients. So a code may not work everywhere the same. So like I mentioned, to validate these algorithms, we conduct 2x2 tables. This is sort of an epi term to validate the test. And we tested over 1,000 different 2x2 tables to identify the children with IBD. What I wanted to bring your attention to was this bottom one, which is really approximately the same as the Manitoba algorithm, the 5 healthcare contacts or hospitalizations within 10 or 11 years. To show you that really it didn't work all that well. The positive predictive value was only 50%, which means for the 183 children with IBD, you had 172 children who had 5 healthcare contacts for IBD who were not in the Sick Kids database and therefore didn't have IBD. And that's for children under 15. When we examined the subgroup of younger children, children under 12, the positive predictive value actually went up and it got better. And so that's really lesson number 3 from this validation study, is that algorithms validated in one age group may not necessarily apply to others. And so the algorithm validated in Manitoba adults didn't work so well in Ontario children, and the algorithm validated in kids under 15 didn't work as well as doing the same algorithm in children under 12. So you have to be careful that the algorithm you're using to identify and the codes you're using to identify the cohort applies to that age group as well. So in the end, we validated a nice pediatric algorithm that worked better in Ontario children than the Manitoba algorithm did. And then we went about also validating an adult algorithm with a separate cohort. And again, that shows you the same thing, is that we took our cohorts from Ontario and we tested all the other algorithms on them, and clearly the algorithms function differently in Ontario from Manitoba, from Alberta. Every algorithm functioned differently in our population, emphasizing that, again, don't assume that an algorithm validated in Manitoba is going to apply to Ontario and vice versa. So anyway, moving on from the sort of hardcore basic science, we sort of kind of looked at the prevalence of IBD in Canada using these different algorithms recently, and we found that the prevalence is increasing very rapidly, alarmingly quickly, in all the provinces examined over time. This black line is the Canada-wide sort of pooled number. What we also found, which was interesting in Ontario, was that although the peak onset of IBD shown by the line graphs here were in people aged 20 to 30 years old, the bar graphs show the percent change over time in the number of new diagnoses, so the change in incidence between 1999 and 2008. And what we found was the group increasing most rapidly, the number of new diagnoses increasing most rapidly, were in children under 10, and then children 10 to 19 years old as well. And that spurred all sorts of new research and new endeavors, both to try to focus the healthcare system on these young children with very early onset IBD, but also to try to find the cause, whether it's genetic or environmental causes, for the rise of this very early onset IBD, led by many researchers across Canada. Because Canada has one of the highest rates of IBD in the world, Canadians have been able to leverage our findings with the healthcare system and population health to try to find the cause and the best treatments for these young children with IBD. So it's something that I'm proud of, that because of these data, we're able to spur new research innovation. But I want to show you something similar from Quebec. When we showed you the Ontario data with the peak onset of 20 to 30 years old, this study was published from Quebec, and they actually applied the Manitoba IBD algorithm to RAMQ data to report the incidence in Quebec. And we spoke about the potential for misclassification, so being wrong about whether you're calling somebody IBD or not IBD when one region's algorithm is applied to another database. But here you also see the age issue. In this study, they demonstrated a higher rate of IBD in children under 1 year old compared to older children. We know that this does not reflect reality. IBD is extremely rare in children under 2. And so what do we think happened here? In my opinion, I think the algorithm didn't work properly in this age group, these children under 1, probably because the algorithm was calling infants with allergic enterocolitis as Crohn's disease, when they didn't in fact have Crohn's. Allergic enterocolitis is very common in in infants. This could have had an impact on planning of the healthcare system and planning of pediatric care, but thankfully this was corrected in a more recent estimate of IBD in Quebec published by Alain Biton and his colleagues in 2014. So lesson number 4 is we can use these data to make important discoveries, but validate, validate, validate. Please make sure that the data is accurate before you make conclusions or change healthcare policy. And I wouldn't be nerdy enough if I didn't put up a Dilbert cartoon. I'll give you a second to read that. So, again, emphasizing the importance of improving transparency and making sure that the reader and the consumer of the research is aware of the weaknesses of the study. Record came up with some other issues that were very important, and I want to bring your attention to the linkage issue. So we had said in the record guidelines, consider the use of a flow diagram or other graphical display to demonstrate the data linkage process, including the number of individuals linked with linked data at each stage, and also how you lost individuals because you couldn't link the databases across each stage. So again, remembering that this review article that we published last year showed that about 40% of studies linked patients across databases, and a good proportion even linked 4 or 5 databases. We gave examples in the record guidelines on how to graphically demonstrate linkage. This was a good example of a good graphical representation of linkage across studies. This study linked 3 different databases on myocardial infarction, and you can see based on how you define your cohort, you're going to lose patients, right? If you want patients linked across all of these different databases, you're going to be losing 8% plus 18% is 26 plus 10 is 36% of your cohorts, just because you couldn't find them across the different databases. This is another example of a linkage diagram. And in this one, they actually produced a table 1 and 2 where they compared patients who were linked to patients who were not linked, and made sure that you weren't biased in who you were included in the study because you weren't able to link them across. So very good examples of good reporting of linkage. And then finally, in record, we wanted to discuss the implications in the discussion section so that the reader and the consumer of the research really understood what the risk of bias was in the study because they used routinely collected health data. So we insisted that authors of the manuscript include a discussion of the risk of misclassification bias, which is that risk that the algorithms and the codes are not classifying patients as having disease or not having disease properly, the risk of unmeasured confounding, of missing data, and changing eligibility over time is a really important thing. In Ontario, it's not so much of an issue because most people who are born in the province stay there for their full lives. They never lose OHIP eligibility. But in places like the US, where they're using claims data based on HMO data, most people in the US will only keep their HMO for an average of 3 years. So it's extremely frequent that patients in these databases can only be followed for 3 years and then they just disappear. There's no flag to say that they're gone. They just change coverage or lose coverage. And so you really need to have look for that discussion in the discussion section of the manuscript to see how it might have affected the study results before you change health policy or before you change patient care. So if you're interested in reading more about the record statement and this issue of transparency, the website is available. All of these documents are available open access for free on the website. You can read the full text. You can read the checklist. There's also translations and commentaries about it. The record statement has been endorsed now by more than 20 journals so far. Many of them are Canadian, which is great. Future steps for record and improving transparency. We're going to continue to further sort of encourage further uptake of record in journals and in policy platforms. So it doesn't just have to be journals that endorse it. Certainly granting agencies, policy agencies, anybody producing reports could endorse record and use them to make sure that their reports are complete and transparent. We're also going to evaluate how record has impacted the scientific literature. We're going to adapt record to studies that are specific to pharmacoepidemiology studies and randomized controlled trials that use routinely collected health data. And I think really our next major step is moving beyond just reporting to providing methodologic guidance and actually engage in teaching of researchers, scientists, but also policymakers, analysts in various places to try to bring to attention these methodologic issues and try to drive the improvement in methodology forward. So that's coming soon. So in conclusion, routinely collected health data can shed light on important health services issues, as I showed you with the lean process. There's potential for intervention that could impact policy, patient care, and cost. And really, sometimes it works, sometimes it doesn't, right? Either our intervention work or sometimes they don't, but more importantly, our interventions may not work because the data and the methodology was not, that we're basing our decisions on, was not accurate. And so the bottom line here is don't just blindly trust the data. I'm not saying don't use the data, but make sure that you verify, you validate, and you clarify, and that everything is transparent in the way that you use the data, because it may come back to bite you. I envision that when we go forward with using these sorts of data, especially as the data sources expand and more EMR data is available, I envision teams of people, including medical bioinformaticians, but also computer scientists, policymakers, and epidemiologists working together to examine not only the logistics of how to use the data and how to program the computers, but whether or not we should be using the data and try to drive the field forward to try to improve the methodology for use of these data. Thank you very much, and I'll take any questions.
All right, thank you very much, Dr. Benchimol. A fantastic presentation, and even if you did sort of stop moving your head and the enthusiasm of jumping around as you're presenting, it didn't come across in your voice. You still seem very enthusiastic about the topic. So, and even though we did get a little bit nerdy in the middle there, I think really some great information. I think it's really valuable to see sort of some of the nuts and bolts of how this works, and in particular when it doesn't work potentially. One of the questions that I had was, this concept of big data, and when we hear about big data, we always hear about these big piles of data that machines go through, and associations and things start to just become elucidated because of the nature of this giant pile of data, and connections are being made. There's always talk of the promise of machine learning, looking at these big data sets, et cetera. So when you're talking about developing algorithms to identify IBD, et cetera, it's still always sort of hampered by the ability of an individual to create as complex of an algorithm that you can in order to, rule out and validate and make it as, accurate as you can make it. Just sort of wondering, in your opinion, what's the role for machine learning in the sense that someone like a Google or an Amazon does when they're looking at millions and millions of photographs, for example, and learning and having a machine learn to identify, key images and that sort of thing. What's the opportunities for machine learning in this kind of thing, looking at health data within Canada?
Yeah, no, it's an excellent question, and I actually had slides on this, but I decided to pull it out because of time limitations, which now I regret, but I think it's the future. I honestly do. I think machine learning and artificial intelligence in using these data are absolutely the future. I'm working with a PhD student who's a student not in epidemiology. It's the first student I've co-supervised who's not in epi, who's in the Telfer School of Management in the e-business program, and who's really a computer science person, not an epidemiologist or a clinician. And what we're going to be looking at is using our health administrative data to try to understand early life environmental risk factors for these chronic immune system diseases like IBD, like asthma, like multiple sclerosis. And instead of being limited by our human capacity for testing, testing questions, testing hypotheses, we're going to let the variable associations and the clustering of variables kind of define themselves, and using these pretty well developed now at this point machine learning techniques that were developed in the computer science realm. However, I think the message of validation is still there, and I think even the computer scientists agree with this message of validation. So while we may find new associations between an environmental risk factor and these immune diseases based on machine learning, it will not be sufficient to stop there. Even if it's a strong association, I think number one, we need to test that association in other data sets. So his intent is then to go do things like clinical data using EHR data and run the algorithm again to see if it works in the clinical data and comes up with the same association. But also, obviously, you have to take that information that you find and bring it back to the biology and bring it back to the basic science lab and try to prove that association in the science. So again, I think I left out that part in terms of the team that I expect. I think basic scientists are going to be part of that team as well, and they're going to be involved with proving the hypotheses that we create. I do think that AI is the future, and I think our methods are developing. However, we have to be cautious, we have to be slow, and we have to validate.
For a lot of people don't know the details of what big data really is and sort of the size of a data set that's required. Some people I've heard people talk about that Canada would always have a challenge in using big data in this way, just in the sense that we often have difficulty combining data sets across provincial boundaries for smaller diseases, even something like IBD. Do you feel we have enough volume of data that would be, for individual conditions like IBD, which isn't all that rare? With the challenges of going across provincial boundaries, even given Canada as a relatively small country on the global scale, or do we have to start looking at sort of more international data sets in order for this to actually work?
Yeah, so if you're talking about artificial intelligence and machine learning, you're right that it probably would be a problem. For example, if we looked at just at IBD using machine learning, we probably wouldn't have enough numbers, despite IBD being about 1 in 150 people in Ontario. It probably wouldn't be large enough. And so, again, the programs that the computer scientists use are able to tell whether the power is there or not to do it. When computer scientists talk about big data, they do talk about at least sort of 1 million observations in the population, so 1 million people in our case when we're talking about population data. So you do have to be careful, and we're still learning about how to do that. I think there's new methods that are coming out now that allow us to amplify the power. So while we might not have enough information in Ontario, for example, with the IBD cohort, I showed you the multiple provinces, we can't share data, individual level data across provinces due to privacy regulations, but what we're doing is we're essentially running the same computer program, the same algorithm, the same analytic technique, using the same variables in each province, and then with producing a result and meta-analyzing, so pooling the results rather than pooling the individual level data to create a picture of what's happening with IBD in Canada. Similarly, there are people who are doing that sort of thing across the world with international studies across multiple countries, and then you can have populations of hundreds of millions. And if you can think, I don't know that this has been developed yet, but if you can think that the computer scientists will eventually develop a way of running the same machine learning programs in multiple places and then combining the results so that you have the power to do that, I think that will be the future. So it depends on what you're looking at. Obviously, if you're looking at one disease that's extremely common, if you're looking at a very common healthcare outcome like hospitalization, Canada would have enough numbers. If you're looking at a rare disease, like a rare genetic mutation, we may not in one province. I would hope that one day we might get over the privacy issues of pooling data, especially when it's de-identified data. It doesn't make much sense to me that Canada's provinces insist on keeping data separate and that each province, because of the provincial administered healthcare system, won't share individual level data with other provinces. I think we're still working that out in terms of the privacy regulation, so that may change in the future as well.
Well, we can all hope for that, because as a national organization and with our data projects, such as the Canadian Pediatric Decision Support Network and our pediatric rehab reporting system, that is always often one of the challenges, as you said, the issues of sharing data across provincial boundaries, which are nothing but regulatory barriers, really, and their necessity is questionable in some cases. So, so hopefully, as you said, we can overcome that. We do have time for one last question. If anyone does have one more question that they're quickly typing in, we may take another second just to see if anyone has any last questions. Otherwise, if we don't have any questions, Dr. Benchimol, I'm just going to hand it back over to you. Just with any closing key messages that you think you'd like to leave the audience with before we sign off. And I'm not seeing any other questions coming in, so we'll hand it over to you one last time. Just anything you'd like to leave the audience with before we sign off.
Sure. Well, I hope I didn't scare everybody against using these data. I know my message was cynical and a bit cautious and conservative. My aim is not to scare people against using these data. I think these data are very valuable, and I think they can change healthcare policy and healthcare administration and improve quality of care being provided to patients. I'm just hoping to impart the need for caution and the need for involvement of experts who use these data prior to changing healthcare policy based on them. I think our knowledge of these data is just developing, and so hopefully we can all work together to try to improve the care of children.
Thank you very much, and with that, I think we will sign off. Thanks again for a great presentation, really thought-provoking, and really certainly giving us something to look forward to in the future. With things like big data and machine learning and all of these other things we keep hearing about in the the worlds of the Amazons and the Googles and all that, and maybe leveraging that to improve health and healthcare for children would be fantastic. So thanks again for a great presentation.
You're welcome.
All right, and with that, we will close off. As many of you know, we do our webinar presentations every Wednesday at 11 a.m. Eastern Time. This is our last presentation before the CAFC annual conference, which I mentioned is coming up on October 22nd to the 24th in Montreal. So we do take a break as we approach the conference, just because we get really busy around here. But we will be coming back in November. We don't have anything on the schedule yet. We have lots, not actually up on the calendar yet, but we do have one in particular that might be of interest to this group. Will be from a group called PolicyWise, which is an organization in Alberta that has the SAGE secondary analysis to generate evidence data repository, where they're going to be, again, similar to today, talking about the secondary use of research data, community service data, and administrative data related to health and social well-being. So it's going to be, again, a very data-focused presentation, but I think very much of interest to the folks who attended today. So hopefully you can join us for that one. And again, details and the dates and everything will be coming out in the next week or so. So make sure you sign up for the CAFC Presents newsletter that comes out every Tuesday if you want to make sure you're informed of all of the upcoming webinars. And for that information and to sign up for that newsletter, you can always go to our website at cafc.org. And otherwise, if we don't see you at the CAFC conference, hopefully we'll see you back on our webinars in November. Thanks everyone, and we'll see you then. Bye.